Thank you so much for having us at this year's board review for geriatrics and palliative medicine. We're excited to talk to you today about time-based billing and documentation related to those opportunities that are beyond the traditional E&M for both inpatient and outpatient billing for established and new patients. Neither Dr. Chai nor I have anything to disclose. And at the end of the session, we hope that you will understand the general principles of common inpatient time-based billing codes, specifically E&M codes, critical care codes, advanced care planning codes, which applies to both the inpatient and outpatient setting, and also how to understand the general principles of chronic care management flow and billing in the outpatient setting. We're going to start in the inpatient side with Dr. Emily Chai.
So let me start with some inpatient changes that took place in 2023. Some of the changes that took place includes the deletion of the hospital observational services and the revision of the hospital inpatient services. Pretty much the OBS codes are now the inpatient codes. So they've been really replaced by inpatient codes. The other thing to note is that prolonged service, which used to be divided into face-to-face and non-face-to-face, has also been replaced. There's only going to be one code for all prolonged services. And we'll go into that a little bit later. So what happened in 2023 is CMS was trying to align some of the coding changes adopted by AMA and CPT. And what they really did was allow clinicians now to choose E&M visit levels based on medical decision-making or based on time. And the time that is now allotted is different. So are the definitions of what could count toward time. They revised the times and they changed it such that medical decision-making is now the key factor for all the codes if you are choosing an E&M visit that is not based on time. The performance of a history and exam is only needed if it is medically appropriate. So let's start talking a little bit about time-based billing. So we talked about it. In time-based billing, you don't need the history, you don't need the exam, you don't even need medical decision-making. What you really pay attention to is the time you see on this right-hand column, right? So for an initial inpatient visit or an OBS patient visit, an initial OBS visit, you're really looking at how much time you actually spent. If you spend 40 minutes or less, you're really billing a 99221, 55 minutes or more, 99222, 75 minutes or more, a 99223. So just sort of keep that in mind that now there is not a separate code for OBS patients. OBS patient and all inpatient patients, the initial visits are billed with the same codes. Same rule apply for subsequent visit. Subsequent OBS visits have the same code as inpatient visits. These are the time adjustments. Now, a straightforward 231 gives you is 25 minutes, a 99232, 35 minutes, and a 99233 is 50 minutes. What does these time include? All these time codes for professional services include all the following. The time you actually spent preparing to see the patient, reviewing the chart, reviewing the test, counts toward your time. Getting a history that may be separate, like talking to the family, talking to the another healthcare professional, that counts toward time. Performing the exam or evaluation. Educating and counseling patients, caregivers, family. Ordering tests, those are probably the ones that you are more familiar with. But referring and communicating with other healthcare professionals when you're not billing for that service anywhere else counts toward that time as well. Even your documentation of the clinical information into an electronic medical record counts toward that total time. If you actually independently interpret test results like an EKG that you interpreted personally, and or you communicate these results to the patient, family, or caregiver, that counts toward the time. Any care coordination that you do not report separately counts toward that time. So as you can see, it's rather easy to achieve the times that we saw earlier in the slides for subsequent visits, right? It seems like 50 minutes is quite a lot, but if you add in all these factors that could count toward professional time, you easily reach that 50 minutes. What does not count are the following. The performance of other services that are reported separately. If you're billing separately or doing it and you're actually reporting that separately, that does not count toward your time for this time-based billing. The time you spend traveling from one unit to the another does not count. If you're doing teaching that is general and that's not limited to the discussion of the patient or the management of that specific patient, that does not count toward your overall time. What are some other inpatient time-based codes? So we talked about each of these E&M codes are now linked to time. The other three are prolonged services, advanced care planning, and critical care. Let's start with the prolonged services because I told you that there was a change. There's no longer a distinction between face-to-face and non-face-to-face billing. All prolonged service codes, face-to-face or non-face-to-face, are additional codes added to E&M. And it can happen with or without direct patient contact beyond the required time. So any service that you do that meets the criteria of the services listed in E&M, except that you spend more time on it, will count as a prolonged service. And you will use the prolonged service codes for those reasons. There are actually prolonged service codes for inpatient as well as outpatient. The general rules apply. The codes, I think, are a little different, but the general rules apply. So the code that exists is 99418 for inpatient, and it's for each additional 15 minutes of service rendered with or without patient contact beyond the time you have reported on E&M. Okay, so remember the highest subsequent visit code time that we sort of spoke about was 50 minutes. You need to at least render a 15 minutes more than that to bill for a prolonged service code. So for example, if you spend 70 minutes in a follow-up, you're going to bill 99233, which covers the first 50 minutes, and you are going to bill a 99418 for the additional 20 minutes because you achieved the 15-minute mark. If you actually spend 85 minutes with a patient in follow-up, you are now going to bill 99233 for the first 50 minutes and 99418 to account for that 35 minutes additional that you've spent with the patient. These are just some additional examples based on sort of the time. If you spend less than 90 minutes for an initial visit, because that's the highest code, you cannot use any additional codes. If you spend less than 65 minutes because you do not meet the 15 minutes or more greater than the 15 minutes, you cannot report it. So these just give you an example of what the time ranges are and how many of these additional prolonged service codes you could bill for. Let's move on to advanced care planning. So advanced care planning is a face-to-face service. So keep that in mind. That's going to be really important. It does require a face-to-face, whether that face-to-face is in person in the office, face-to-face via a video visit, but telephonic visits do not count, at least for now. So face-to-face is really important. It's a face-to-face service between a physician or healthcare provider to a patient, family member, or a surrogate in the discussion or counseling regarding advanced directives. It does not require you to complete legal forms. It just needs to be a discussion or counseling regarding a plan. It is voluntary. It can be billed in the inpatient or the outpatient. It could be an add-on service or a standalone service. If you do decide to use it as an add-on service, the modifier 25 needs to be added to the primary service to let them know that there is another service being provided that is separate from the primary service. So remember, the prolonged service codes do not need a modifier. Advanced care planning codes do need a modifier. Let's go through a quick example. So you have an 68-year-old male with heart failure, diabetes, on multiple medications seen by his physician for the E&M of these two diseases, including adjusting medications as appropriate. So in addition to discussing the patient's short-term treatment options, the patient expressed an interest in discussing the long-term treatment options and planning, such as the possibility of a heart transplant if his heart failure worsens. He wants to talk a little bit about his desire for care and treatment if he suffers a health event that adversely affects his decision-making capacity. So you've taken care of his heart failure, you've taken care of his diabetes, you dealt with the medications and the plan, and now he wants to do some advanced care planning. So you're going to actually document the conversation that you're having with him. That includes who was present for discussion, if legal forms were filled out, what those forms are, document the patient and the healthcare person's preferences, and then really document your goals, questions that were answered, and your total time spent in the advanced care planning. If you actually spent 30 minutes or more, the initial 30 minutes is covered by the code 99497. Every additional 30 minutes, you could bill another code of 99498. You could bill usually up to 3 codes of additional 99498. And that's so just to remember, advanced care planning, face-to-face. It's an added code to a service. If you do it as an added code, it needs a modifier. It can be also a standalone code, in which case you do not need any additional modifier. Let's move on to critical care codes. Critical care really refers to high complexity decision making to support vital system functions. It could be one organ, multiple organs, but there needs to be some organ failure. And you need to have a conversation or a plan in place to prevent further life-threatening deterioration or worsening of the patient's condition. What you'd really need to document are listed below. There needs to be an organ failure, as I said. Usually in critical care billing, the patient usually lacks capacity or does not have capacity. So very different from the face-to-face we saw earlier. This patient does not have capacity. You need to make a determination of what to do next. You don't need face-to-face. So if you called a family to engage in discussion, it could be billed as critical care. Okay. And whatever you need for this organ failure, decisions need to be made. And very soon, because this is an acute change. We're not talking about the future as we are doing in advanced care planning. We're talking about the here and now when something acute had happened. You want to document who was present for the discussion. And as with all time codes, make sure you document the total time you've spent discussing this new change with the patient's family or surrogate or decision maker. So let's go through a couple of quick examples. A 70-year-old man admitted for right lower lobe pneumococcal pneumonia with a history of COPD. Now suddenly becomes hypoxic and hypotensive 2 days after admission. If you actually have a discussion with the family about sort of what the next steps are, that can count toward your critical care billing. Okay. Management of a dialysis or related dialysis care for a patient receiving end-stage renal disease hemodialysis. If it's an acute change, yes. If this is a routine change, you're not going to be able to bill for critical care. It's a failed organ, but something needs to be changed for it to be critical. So someone who has no change is receiving just hemodialysis, that's not a critical care bill. 68-year-old admitted for an acute anterior wall MI, continues to be symptomatic, to have symptomatic ventricular tachycardia that's marginally responsive to antiarrhythmic therapy. An acute change has occurred. You need to make a decision about what to do next. This qualifies as a critical care billing. Well, what else do not qualify? Just because the patient's in a critical care unit and there are no other hospital beds, you cannot do critical care billing. The reverse is true. A patient in a regular bed, you could do critical care billing if they meet the criteria. So patients admitted to critical care unit for close nursing observations or frequent monitoring of vital signs do not count, right? They don't meet the criteria we talked about. Patients admitted to a critical care unit because hospital rules require certain treatments like insulin infusions needs to be in a critical care unit. Does not count unless you are deciding whether or not to start the insulin infusion. That conversation will count, but subsequent encounters will not count as critical care billing. So a couple of quick questions. Keeping in mind medical necessity and acutely ill, okay? Patient being in the ICU is not sufficient for critical care billing. Patient on a ventilator alone is not sufficient for critical care billing. They will meet the need if it's an acute change requiring intubation and you're making that decision. The threat of imminent deterioration, a condition that would result in morbidity or mortality, that will qualify for critical care billing. Emergent treatment of acute dyspnea and agitation of a critically ill patient will qualify for critical care billing. Counseling and bereavement support do not qualify, even if the patient is in the ICU. So let me quickly go over this one inpatient case to show you the complexities and the options available in inpatient time-based billing, and I'll turn it over to Dr. Chun. So a 74-year-old woman with hypertension, diabetes, peripheral vascular disease is now admitted for sepsis. She was confused on presentation and an exam revealed wet gangrene on her left big toe and acute on chronic kidney disease with a creatinine of 6. You came up with a treatment plan for her medical problems and updated the nurses and her daughter. You spent a total of 90 minutes on the care of this patient. What are your billing options? Can you bill for critical care? Well, let's look back at the case. So they meet criteria. This is an acute change, right? She has acute on chronic, and now she needs dialysis. She has an acute infection that you need to determine whether or not you want antibiotics for. Both of these can cause, has impact on morbidity and mortality. So yes, you could use critical care billing for this. You spend a total of 90 minutes. And if you were using this table, 90 minutes means you could bill $992.91 for critical care, and you bill $992.92 for an additional critical care code. Why does this table look different? It has a different set of times on the left. We said 90 minutes. According to this table, you could only bill $992.91 once. There is no additional code. Well, the problem is that in 2022, CMS regulations required a minimum of 104 minutes to support the payment of $992.92 by Medicare. So this second table I'm currently showing you is what the Medicare actually looks at. Okay? Everybody else still looks at the first table. So if it's not a Medicare patient, you could actually bill an additional code of 99292. However, if it's a Medicare patient, Medicare did their revisions and decided that you could only bill for a 99291. So you will have to decide how you are going to resolve how you are billing based on insurance. But I just want you to be aware that there is a difference between whether a patient has Medicare or private insurance when you're billing for critical care. Advanced care planning, if we spend 90 minutes, you bill 99497 and 99498. If you decide to do this as a prolonged service code, remember you bill 99223 first if it's an initial visit. And you could add a 99418. Remember, the modifier 25 needs to go on the 99223. For prolonged service codes, you don't need a modifier. It was the advanced care planning code, you need a modifier if you have an initial visit. Prolonged service codes, you do not need a modifier. So you'll be billing 99223 plus 99418. If this was a follow-up visit where the highest code for time is 50 minutes, then you will be billing 99233 plus 99418 times 2. In summary, prolonged services now does not require direct patient contact. It basically requires that you spend the time beyond the time that was allotted in the E&M code, and you're going to be using 99418 for each additional 15 minutes beyond that primary code. Advanced care planning codes can stand alone. If you do use it with an E&M, you do need the modifier 25 on the E&M code. And critical care codes are all time-based, and it's the total time for caring for a patient. Remember, you do need to show that there is an organ damaged, and you cannot use that together with an ACP code. And with that, I turn it over to Dr. Chun.
Thank you, Dr. Chai. So we're going to switch a little bit. I will make a comment related to Dr. Chai's slide from before that while critical care codes are not billed outpatient, the ACP and the prolonged services are. The ACP codes are the same code for the prolonged services. For the add-on, it's 99417 as opposed to 99418, but the principles are exactly the same. All right, so we're going to move on to outpatient opportunities for capturing the work that you and your team are doing, specifically related to chronic care management and complex chronic care management billing. Next slide. So exactly what are we talking about when we talk about CCM or chronic care management? The extra C is when it's complex chronic care management. And what we mean is this is a critical component of primary care that contributes to better health and care for individuals. And in fact, CMS in 2015 began paying separately for this service for patients who had multiple chronic conditions, which was defined as 2 or more. It was for services that were related to non-face-to-face care management, so not in the office actually, but could be done over the telephone or other means. And most importantly, it was both physician and team member time. So this was really revolutionary in many ways for paying for services that were not face-to-face and also that were not necessarily 100% by the physician. Next slide. So there are a number of changes that occurred after 2015 when the first code was introduced. So 99490 was the initial chronic care management for non-face-to-face care. In 2017, they actually updated this to account for complex chronic care management, and we'll talk about what that means in a minute. and added 2 additional codes, along with a code for making an initial care plan, which can only build once. In 2020, some additional updates were made to clarify the time that was required to bill for each of these types of chronic care management. And additionally, recognizing that it can be more complex for the patient, and certainly the time that's being spent when it's physician only, a physician only time code was added. And there was an update to the additional time increments from a G code to an actual CPT 99439. The other major thing was initially it was only available for our Medicare beneficiaries who had fee-for-service Medicare, but in 2020 it was expanded and required that all MA plans included should reimburse for chronic care management services and not only for fee-for-service patients. So this is a slide of all of the codes that are associated with this family, chronic care management, as well as complex chronic care management. The times that are required for each of these are also listed along with the work RVUs and payment for a non-facility setting. This is the average payment. Regionally, there will be differences based on where you practice. Chronic care management, each of these codes has a base code and then a time add-on code, and I'll give an example of that a little bit more. But chronic care management for staff time starts at 20 minutes. So if you have a patient who's eligible for chronic care management, after 20 minutes of care in a month, you can bill for those services. There is an add-on code for that basic chronic care management of 20 minutes each that can be billed twice, so up to 60 minutes. Then there's complex chronic care management, which begins at 60 minutes of care services rendered with an add-on code of 30-minute increments to that with no limit. Finally, there is the chronic care management physician-only time that begins with providers themselves, not staff members, but the physician themselves spending 30 minutes on care management, non-face-to-face, with add-on codes for their time as well. And finally, an initial care plan creation is the G0506. This can only be billed once with the initial care plan creation. So who qualifies for chronic care management services? Any Medicare beneficiary, both fee-for-service and Medicare Advantage programs, must pay for chronic care management services. The patient or the beneficiary must consent to the services. They only need to consent once, and that consent can be either verbal or written. It's not required to be written consent. Verbal consent is acceptable. The patient or beneficiary can certainly rescind their consent at any time, but at the time of consent, it's considered to be active going forward. The beneficiary who qualifies is any person with 2 or more chronic conditions that can place the beneficiary at risk for death, acute exacerbation, decompensation, or functional decline. There must be a care plan that's shared with the patient or available to the patient, and the updates are needed only as necessary. There is no defined frequency. At the beginning of chronic care management in 2015, there was a requirement of an annual care plan update that has since been revised so that a care plan is only necessary as conditions change. And the time can be certified by any team member. This non-face-to-face time, again, can be by the physician. It could be done by other members of your team, including social workers, nurses, nurse practitioners, other people on your team who are providing non-face-to-face care coordination. So once you know who qualifies, any beneficiary with 2 or more chronic conditions that puts them at risk for morbidity, mortality, exacerbations, if you supply at least 20 minutes of non-face-to-face care coordination time in a month, that person, that service is potentially eligible for billing. Again, it can be any provider on the team, so any team member, not necessarily just the physician, but only one practitioner can bill per month. So you can't have 2 people billing for chronic care management services within a practice. There are some services that cannot be billed at the same time as a chronic care management per month. Transitional care management is one of them. Care plan oversight for home care orders, certain bundled end-stage renal disease services. And there is a caveat related to the transitional care management. Generally, they can't be billed in the same month. So a patient is discharged from the hospital, is seen for transitional care management. The transitional care management is supposed to be inclusive of non-face-to-face care management for 30 days after their discharge. However, there could be a circumstance if someone was admitted and discharged in the month prior. So let's give an example of June 16th. They were discharged from the hospital. They were seen on July 1st for a transitional care management visit. That transitional care management is supposed to be inclusive of non-face-to-face care time for 30 days total. So that would take you into July 15th. If you provided more than 20 minutes of chronic care management services after that 30-day discharge date, then potentially it could be billed because you would not be kind of double dipping services. That being said, I think it's pretty complicated to try to keep track of all of that. So I probably would not advise you, and it's probably just easier as a rule to not bill the same month that you do transitional care management. But there are circumstances, just so that you are aware, where it can be billed. So I've given a lot of information about who qualifies for these services. And so you can imagine it's very important to have a workflow in the practice that everyone is aware of and that everyone can follow in order to keep track of all of the things that need to occur. So remember that eligible patients for this service are those with Medicare, either fee-for-service or managed care, who have 2 or more conditions. So you need some system in which to identify which patients are identifiable and eligible. Once you identify these patients, then you need to obtain consent. Again, it can be verbal or written, and you need some way of tracking who has consented to these services and who has not. Once you've identified the patients, you have their consent, then you want to create a care plan that is available for the patient. And then finally, you need to be able to document the amount of non-face-to-face time that your staff or your team and physicians are spending in care coordination. Once you have a system to do all 4 of these things, then you need to identify the total time spent in a month, in a calendar month, of non-face-to-face time that's occurred. And those who have done 20 minutes or more of this service, when that has occurred, that person, a provider is able to bill for chronic care management. So it seems pretty convoluted, but if you have an established workflow, this can go pretty quickly and easily. But all of these things need to be met in order to bill for these services. What does the care plan need? The care plan that's required by CMS is not immediately prescriptive, but there are some things that need to be included. They include the problem list, the expected outcomes and the prognosis of these conditions, specifically those 2 or more chronic conditions that you are managing. Are there any measurable treatment goals? There should be a cognitive and functional assessment at some point in time, as well as management of symptoms, planned interventions, medical management, environmental evaluations, caregiver assessments, interactions and coordination with outside resources, a periodic review, and when applicable, a revision of these care plans. This seems like a lot, but these are things that we're generally doing with geriatrics care, and so they're inclusive of all the things that are occurring for the patients in their conditions. So finally, how do we get to bill? So remember, going back to that workflow, you've identified the patients who are eligible, you've obtained consent, they have a care plan, and you have a system in which to document the amount of staff, team, or provider care coordination that's occurring in a month. At the end of the month, if someone has 20 minutes or more of this type of non-face-to-face care, you can bill for that month. There are 4 codes potentially that you're billing. Typically, 3 of them are the ones that are being used related to that non-face-to-face care coordination time, and 1 is a single use code for when the care plan is created. The first code, 99490, is one of the base codes for staff time of at least 20 minutes in a month. If more than 20 minutes is given, if it reaches a threshold of 20 minutes or more, then you can bill for an additional unit with this add-on code for 20 minutes of 99439 with a maximum of 2 units, which gets you to 60 minutes. Unlike many of the other time-based codes, where if you get 50% more than the 20 minutes or the 10 minutes, the halfway point time, this one actually requires that you use the entire 20 minutes before you can build that time-based code for all of these in the category. The next step up is for those with complex chronic care management. This code requires a minimum of 60 minutes, 60 minutes, and the same concept applies. If an additional 30 minutes is provided in that month, you can bill for both the complex chronic care management code with additional units with no limit of the 30 minutes in 30-minute increments of additional time that's spent per month. Finally, for those minutes or time spent in non-face-to-face care coordination by physician only, there's a code 99491 that begins at 30 minutes. And once again, in the same way, if you spend 30-minute increments in addition, those can be added on to that base code. Go on to the next slide. So giving an example, chronic care management 99490 with additional 20 minutes. So each additional 20 minutes of staff time directed by a physician or other healthcare professional in a calendar month can be counted for the total time that's being spent in chronic care management. When that is being used, use the base code of 99490 in conjunction with multiple units of 99439, the 20-minute code, depending on how many minutes are being provided for that month. So you cannot bill for 99439 for units that are less than 20 minutes. So you must meet the full 20 minutes, and the time ranges are listed in the table below. So if you have less than 20 minutes total of any chronic care management, 15 minutes, 16 minutes, 17 minutes, 19 minutes, you cannot bill for chronic care management. Once you are able to reach that 20-minute threshold, then you can bill for chronic care management 99490. So 20 to 39 minutes. So if you spent an additional 19 minutes in staff time and care coordination, it's still only a 99490. However, if you reach that 20-minute threshold, at least 40 minutes total staff time or provider time in combination, in any combination, then you can bill both the 99490 as the base code plus 1 unit of 99439 for the additional 20 minutes spent. Again, if you spent an additional 19 minutes, you can't go to the next unit yet. You need to do the full 20 minutes. So when you reach a threshold of 60 minutes or more of non-complex care, you can bill the base code of 99490 with 2 units of the 99439, which is the 20 minutes. Even if you bill more, there is a limit to the number of times you can bill the 99439, which is 2. So you only can bill up to 60 minutes plus, but additional 20-minute increments does not count. So similarly, complex chronic care management, these are for more complex patients, typically with 2 or more chronic conditions that are putting them at risk for disability, exacerbation, morbidity, mortality. But if you reach a threshold of 60 minutes, 60 minutes, then you can build a code 99487. So again, if it's less than 60 minutes of non-complex care coordination, you need to be billing the chronic care management codes. But if you reach a threshold of 60 minutes and it is complex chronic care management, then you can begin with the 99487. Once you reach a threshold, this time it's 30 minutes as opposed to 20 minutes, you need to reach the full threshold of 30 minutes in order to bill for the additional units of time. So in the table, you can see for 60 to 89 minutes, it's the 99487 alone. But once you reach 90 minutes of care coordination, you can do the 99487 plus 1 unit of the 99489 for 30 additional minutes. And then you need to meet the next threshold of 120 minutes in order to bill 2 additional. There is not a limit to the number of these additional time units that you can use for 99489, you can imagine it's a significant amount of time. But if this is what you are providing to the patients, to the beneficiaries, then certainly you want to get credit for the important work you're doing. So in summary, for chronic care management building, the most essential step is to create a practice workflow. Without this, it's near impossible to bill for these services. You need a workflow that identifies who is eligible with Medicare and 2 or more chronic conditions. You need a workflow that can identify who needs consent and who has already obtained consent or granted their consent. You need to create and share a care plan. And you need a system in which to document and track the non-face-to-face time of both staff and physicians. And importantly, to be able to differentiate between staff and physician time, because there are billing opportunities for physician-only time. Once you are able to do all of these things, you also need a way to identify monthly, either through a report or through an alert, of those patients who have met a threshold of 20 minutes or more for non-face-to-face care coordination time, so that you can choose the appropriate billing level for the services provided. Finally, when you are able to bill, you want to remember to use the appropriate base code: chronic care management, complex chronic care management that includes both staff and physician time, or chronic care management for physician-only time, which begins at a threshold of 30 minutes of physician-only time. And based on that, using the additional time code modifiers to really fully get credit for the work that's being done. And as a reminder, the initial care plan creation can only be billed once in the beneficiary's lifetime. You do not bill for revisions of that care plan, only for the creation of the initial one. So before we get to our final summary, we have a question for you all that's based on time-based and billing documentation. So all of the following activities qualify as professional time for time-based billing, except preparing to see the patient, B, performing a medically appropriate examination or evaluation, C, referring and communicating with other healthcare professionals when not separately reported, or D, teaching that is general and not limited to discussion that is required for the management of a specific patient. So which of the following is not qualified as professional time-based billing? So the correct answer is teaching that is general and not limited to discussions of that specific patient for management. So remember, all of the ones above do qualify for professional time-based billing, even if it's not necessarily face-to-face with the patient that day. It must be services that are on that day, so preparing to see the patient and doing these other things, but general teaching is not part of the time that you can count towards time-based billing. So we hope after this session that you understand that medical necessity is the overarching principle, and that time should reflect your medical necessity, but is another way of capturing the work that's being done throughout the day and not necessarily related to face-to-face time, seeing the patient on the day of billing and the service. It's quite important to understand documentation guidelines and keep a reference or a template that helps you meet all of the criteria needed. Appreciate that there are various coding options. So Dr. Chai gave some excellent examples about how a clinical scenario could actually be billed in several different ways appropriately, depending on your comfort with your understanding of those different things and if they meet all of the criteria of those areas. And finally, although we are giving our perspective and our interpretation and how we do at our own institution, we understand that compliance may interpret some of these rules a little bit differently, a little bit stricter, a little bit looser than the ones that we presented. So it's important for you to be in contact with your compliance office to make sure that you are meeting all of the standards of time-based billing for your specific institution. We also have included some resources for your reading interest and also as references to go into a little bit more detail to these areas of billing. And we really want to thank you for your time today. And we definitely want you to get credit for the important work that you're doing. And we hope this is helpful in allowing you to do that.